Thank you for joining us for tonight's educational webinar on If You've Ever Been Told You Have Arthritis, What Now? Tonight's speaker is Dr. Michael Cannone, OrthoNeuro Orthopedic Surgeon. Dr. Cannone is a board-certified orthopedic surgeon specializing in adult hip and knee joint reconstruction and sports medicine. His special interests include arthritis, joint replacement techniques, including unicompartmental knee arthroplasty, ACL reconstruction, arthroscopy, and sports medicine. Please type your questions in the Q&A box below, and Dr. Cannone will answer the questions following his presentation. Dr. Cannone?
Hello, how are y'all doing tonight? So I'm going to go ahead and share my screen with y'all here today so we can get this going. I don't know how many, I don't know who's on the webinar, so I don't know how many have I maybe seen already in the office, or how many that we may have. So what were you saying? Been referred to the practice, but I am an orthopedic surgeon. I do specialize in hip and knee arthritis, as well as some sports medicine. And if you have any questions at the end, I'd be more than happy to answer them for you. So I think to start this out, we need to discuss what arthritis is, and then how not to be afraid of it, and how to proceed to keep our lifestyles active, and to get the most out of what we need to do. These are my disclosures for this talk. I am a consultant for Stryker and Next Step. And I do have interest in New Albany Surgery Center, as well as the Pickerington Surgery Center. So arthritis, when you think about what it is, it's the leading cause of disability worldwide. And although this picture here may turn you off a little bit, it's a picture of the knee, the end of the knee joint. And I thought you'd be interested to see exactly what arthritis looks like. So instead of these bones, the end of these bones being slippery, shiny, and white, like a normal joint should look, you can see the tan color in there is all exposed bone and erosion from the arthritic change in the different areas in here. You can see in here. It affects well over 60 million people just in the United States alone. And obesity, once again, remains a significant epidemic within the country that we live in and worldwide, but more so within the country that we live in. So the majority of patients are age 55 and over, and there are patients that are younger. We're seeing younger and younger patients, but the majority that we're talking about, usually over the age of 50, 55. The knee is more commonly affected than the other joints, and there's somewhere in the range of 2 million hip and knee arthroplasties performed annually. Articular cartilage wear is associated with joint pain, stiffness, loss of motion. We look at x-rays to look for joint space narrowing, bone spurring, what we call sclerosis of the ends of the bones. And sometimes we even see some cysts on x-rays. A lot of times you'll come into the office and you'll say, oh, I've already had x-rays, but we get specialized x-rays. And you can see here, this is an example of why we do that. On this x-ray on the left side here, this is the outside of the joint here, and it looks like this space is completely normal. However, when we weight bear the patient and bend the knee slightly, you can see how the joint has significantly narrowed down here to essentially bone-on-bone arthritis in that outside compartment of the knee. Once again, the etiologies, obesity is probably the most common etiology that is treatable and modifiable. Age, you can't modify that. We're all going to get older no matter what we do. Gender, well, essentially you can't modify that. Ethnicity, genetic predisposition, all those things are not modifiable. Trauma, if you've had it, once again, it's not modifiable, but obesity and weight gain certainly is modifiable. So when you think about arthritis and your body weight, You can think of it in terms of 1 pound of body weight's the equivalent of 5 to 10 pounds of force across the joint, depending on what activity that you're doing. Loss of weight then would equilibrate to decreased symptoms and also the pace of progression of the knee. Once again, if you think about that, that should put a smile on your face. That's my little granddaughter there in the middle, by the way. So when we talk about treatment, education is very important. You have to know what you should and shouldn't be doing. For example, okay, I'm going to go start to exercise. Well, that may be a good option for you, but the trainers that you're working with have to realize that they're not training an 18-year-old high school athlete or college athlete to get back to playing basketball or football or whatever they're doing, and they have to modify what they're having you do. So sometimes that means that you're not bending the knee deep as what they would want you to do. Sometimes that means modifying to less equipment, different equipment that you use less weight bearing on or less high impact stress on. So something maybe such as an elliptical machine or a swimming pool, a rower, something of that nature that that may help to not load the joint quite as much. Weight loss, obviously, that's what we're searching for, but weight loss that's sustainable and that can be maintained. So going on these yo-yo diets, like I'm going to go on this diet and, oh yeah, I lost 50 pounds on that diet, when then 6 months later I gained 60 pounds back. That's not what we're looking for. We're looking for something that is sustainable, that you can incorporate into your lifestyle and maintain long term, whether that's having the assistance of maybe a medication on board with it, or exercise and watching the certain types of foods that you're eating. I think if you want to look at one particular diet that's best for arthritic symptoms, it would be the Mediterranean diet. It's called also an anti-inflammatory diet. And it's the most sustainable, I believe, of all the different diets that you would look at. And the food on the diet is stuff that you would want to eat: a lot of chicken, a lot of fish, less things of beef or that nature, and even some pork and veal is on that diet. Exercise, physical therapy, things certainly that are going to want to be in your wheelhouse of activities to perform. And then when you look at different treatment options, braces are sometimes requested, but as you can see in this picture here, this brace is not something that most patients would intuitively want to put on and walk around the neighborhood in, or walk around the grocery store in. And they're very expensive. You're looking at a cost of anywhere from $600 to over $1,000, depending on if you need to get a custom brace or not. And let's face it, most patients that are suffering from arthritis, legs don't look like this leg here. A lot of times it's a pear-shaped leg or a big thigh, and it's difficult to fit. And then you're looking at a custom option to have to get that brace to fit. But I'm all for, if you're willing to wear it, trying it at least as a non-surgical treatment option. And then from a medication perspective, Tylenol is a fantastic analgesic. It's not as much of an anti-inflammatory. And you have your non-steroidal anti-inflammatory drugs, where there's many different options over the counter as well as prescription. The problem with anti-inflammatories is the associated complications of taking them long term, such as kidney failure, GI issues with ulcers, and GI bleeding. So you want to make sure that if you're taking an anti-inflammatory, that you're getting monitored for that medication that you're taking with your kidney function. And if you're getting any type of dyspepsia or pain in the upper part of your abdomen, then talk to your family physician about the possibility of further evaluating that. As far as injectables and other treatment options, glucosamine, I tell patients glucosamine. Some patients, believe that they get good relief with it. I don't believe that even today there's any really good literature that shows from a double-blinded study that it makes a difference. But There's plenty of patients taking it and feel that they get relief with it. So I tell patients, take it for at least 3 months. If you feel like you're getting relief with it, continue to take it. If not, then don't waste your money on it. There's different types of injectables. Obviously, cortisone is the drug that's been injected more than any other. There are some studies that do show cortisone can actually progress arthritic or accelerate arthritic progression within a joint. That's why I don't put it in a hip, because in the hip joint itself, now not in a bursa of a hip, but in the hip joint itself, the joint is so small, and if that cortisone that you put in there crystallizes, it can be like putting sandpaper in that joint. So I would try to avoid that in the intra-articular portion of the hip joint. In the knee, there's more room for dissipation, and a lot of times the horse is already out of the barn and running, so to speak. And we're just trying to give you some relief and maybe allow you to tolerate physical therapy a little bit better, maybe prolong being able to keep that knee. Other injections that you may hear advertised on the radio around town here are these stem cell injections or PRP injections. Stem cell injections have fallen off quite a bit because of the host coming from them. There was a lot of companies that were poorly creating stem cells and marketing them from non-FDA approved sources, from umbilical cords and things like that. And so we've seen a big fall off on since COVID on the marketing for stem cells. And we really don't know what the long-term effect of them is. There's not been any long-term study that shows, okay, if you get these injections into this joint with stem cells, it's going to save that knee and recreate cartilage in it for 20 years. Well, that study doesn't exist. If it did, then everybody would be getting stem cell injections, and it may be something in the future that's done. You can't get stem cells from your own bone marrow with a bone marrow aspirate, and there's some people that are doing that. But then that involves, sticking a trocar in your pelvis, trying to suck some bone marrow aspirate out of that, and then inject that, spin that down, and then inject that in the knee. There's also platelet-rich plasma injections, and those injections involve drawing blood from your arm, taking that blood, spinning it in a centrifuge, and drawing off some of that, and spinning it again for a second spin to get a high concentration of platelets, and then injecting that into the joint. And most recent literature shows you want to get 6,000 to 7,000 or 6 to 7 million cells per cc of fluid to get a good result, or a good long-lasting result. And those results are similar to the injections with hyaluronic acid, which are the gel injections that you see advertised. I kind of tend to lean towards those injections because when you're talking about stem cells or PRP injections, those are ordinarily not covered by insurance companies. They're listed as experimental. And the hyaluronic acid injections we've been doing for over 30 years now. They were first established and used in veterinary medicine in horses while racing, to diminish the joint pain of horses while racing. And that has then been subsequently transferred to humans, where they've made a human variation of the hyaluronic acid injection. Originally, Synvisc was the first one. It came in 3 to 5 injections, and then subsequently 1 injection. And it doesn't work for every patient, but if you've had these injections and you get relief with them, then there's no reason not to continue doing them. And some patients will get to a point where they say, well, I've had these and let's just take care of the problem. And they've made the decision that they want to proceed with joint surgery. Now, those injections are good for knee issues, but they're not approved for hip injections. And as a side note, Anthem Blue Cross Blue Shield does not cover hyaluronic acid injections. They're the only insurance company out there that does not do that. Oops. You can, I need to go back here. Hang on. So you can go to, you can consider arthroscopic debridement, but insurance companies are becoming less and less willing to allow that as an option. But I would say in a younger patient, maybe 30 to 45, if you do still have a little bit of articular surface left, and you're trying to, maybe get 5 to 10 years out of that knee, doing a arthroscopic debridement and cleaning up the cartilage may be an option for you. It can actually also, though, accelerate the arthritic change and make symptoms worse. So sometimes we'll consider doing that, and then in conjunction with that, after recovery, then proceed with maybe some gel injections and things of that nature. There's some cartilage repairs that can be done. The one on the left here shows some juvenile chondrocytes which have been implanted into that knee joint right there, and then it's covered with some glue, and that will allow articular cartilage to form over that area. These are really good, and this other one here is good for like isolated defects. So if the rest of the knee looks really good, and there's just one area that's affected, sometimes one of these two procedures may be an option. You can see the one on the left has the juvenile cells in it. The one on the two on the right are a synthetic graft that's sewn in there as a scaffold for the articular cartilage to grow into. And both of these patients that had this procedure done did very well, but once again, they were very isolated defects. It wasn't somebody that had global arthritis, all throughout the joints. It was just a focal area that was affected. As far as arthroplasty is concerned, the picture on the left shows an implant of a tibia, patella, and femur that is going to be implanted into a knee joint. Patient on the right is getting a total knee arthroplasty. Once again, you can see the big leg, making it a very challenging case to perform. So in addition to those types of things, we need to continue to pursue established protocols, physical therapy, medical management, as well as optimization of patient factors, such as diet, if you have diabetes, maintaining a hemoglobin A1C of less than 8 prior to considering anything surgically, making sure that you're optimally tuned up to have the best opportunity to have a good result. And then post-operatively using a multimodal pain management system with different types of options and medications, including narcotic medications, muscle relaxers, and neurologic medications. And one other thing that we've been doing in Medicare patients preoperatively is using what's called this NALU nerve stimulator to help control postoperative pain. And in the patients that it's worked in, we've seen a dramatic decrease in the number of narcotic medications they've had to take, and an increase in range of motion and faster progression in physical therapy. But not every patient that's had it so far has had that experience. We've had a couple out of maybe the 40 that we've had put in not have that experience. And then consistent surgical care, limiting the amount of time under anesthesia, limiting blood loss, and maintaining a consistent approach to the joint and avoiding trauma to the soft tissues. That's all I have for tonight as far as that, but I'm sure you all have questions, and we can go from there.
Thank you, Dr. Cannone. So our first question is, how many total knee replacements do you do in a year?
So total knees are more common than, first of all, total knee replacement is more common than total hip replacement. And can you see me on the screen now, Heather, or is it still?
Yes.
Okay. So total knee replacement is much more common than total hip replacement at a rate of about 3 to 4 to 1. So for every 3 to 4 knees you do, you may do 1 total hip. And part of the knee replacements include partial knee replacements. Those are very good in certain patients with isolated pain to one compartment of the knee. We do somewhere between 300 and 400 knee replacements a year. And all of them, for the most part, are outpatient procedures. If we're doing them at the hospital, they're outpatient extended recovery, meaning that you're a patient that needs to be done at the hospital because of your medical history or the of your body habitus. If your BMI is too high to be done at the surgery center, then you would be done at the hospital, and an opportunity to spend the night for further medical observation if necessary. So in higher risk patients, we're going to do those at the hospital. They're still done outpatient extended recovery. Some of them that do well can end up going home the same day. Some of them will spend that night. And then the ones that are done at the surgery center, those are, they go home the same day. And I can tell you, once you get that seed planted in your head that you're going to get it done at the surgery center, you're going to go home the same day. Those patients really are chomping on the bit to get out of there. They don't want to stick around. They want to go home. And that's your best and safest place to recover is at your own house.
What is the best way to lose weight with knee arthritis?
I tell patients, first of all, you got to look at your diet and you've got to start eliminating added sugar from the diet. So that means your salad dressings, your ketchups, your anything that you're eating, you need to look at the label and make sure that it doesn't have added sugar to it. Meaning, if you look at the ingredients that are on the label, they're listed in the quantity of what's in it, so the percentage of what's in it. So if you're looking at ketchup, it'll be tomato, water, cane sugar. So the third most prominent ingredient in that particular ketchup is cane sugar. Well, you obviously don't want to get that one. You want to get one that doesn't have cane sugar in it. So you have to look around, and there's more options available today than there has been in the past. Breads and things like that, starchy things, also build fat, because any excess carbohydrate that you have is stored as fat. And so things that you can just simply do is limit the amount of bread that you're eating, limit the amount of starch that you're eating, and avoid the added sugar. Once again, I've talked to patients about doing the Whole30 diet. I don't think the Whole30 is something that is sustainable long term. Your body just craves things that aren't on that, like pastas and breads and oatmeals and that type of stuff. And so in my mind, it's not very sustainable. The Mediterranean diet, which is an anti-inflammatory diet, is very sustainable. You can do that long term. Obviously, from an exercise perspective, get in the swimming pool. The swimming pool is going to give you your best chance at being able to be functional, because that buoyancy of the water takes away the gravitational force on your joints, allows you to get an aerobic exercise. And after you start to lose some weight, you can then convert that to more of a land-based program in conjunction with the pool. But I'll tell you, so my daughter was just out of town and was talking to a friend of hers out of town, and the lady that she was talking to, this was like, I don't know, 4 weeks ago, 5 weeks ago, had started making these changes in her diet and getting more active with her activities, walking and exercise. And she actually has gone down 2 pant sizes within like a 4 to 6 week period of time, from getting a 31 waist down to a 29 waist. So pretty impressive. If you have to want to do it, and if you want to do it, then you will do it.
Can using a cane prolong my need for surgery?
I won't necessarily prolong your need for surgery. It may, allow you to be less symptomatic for shorter periods of time. But it's, you're the one that's going to decide whether or not you want to proceed surgically. So it's not going to modify the fact that you have arthritis, and it may allow you to stay a little bit more active. And obviously, if your gait is off because of your arthritis, we certainly don't want you stumbling and falling and fracturing something that would be, the worst case scenario. Your wrist, your shoulder, your hip, something around the knee, that would be a bad deal. But yeah, and I think the canes probably help a little bit better with hip arthritis than knee arthritis.
And how will I know when I need a total knee replacement?
So I tell patients, I mean, some patients will come in and they're like, I'm done. I just don't want any, I don't want any injections. I don't want any drugs. I can't tolerate physical therapy. Just fix my knee. Other patients like, okay, I just want to know it was arthritis and I'll try these other things. And, but I tell patients that when you start making decisions to not do things because of your arthritic joint, that's the time to consider doing surgery. So for example, I'm not going to the kids or grandkids game because by the time I walk that distance and get in the car and come home, I have to pay for it for 2 or 3 days. Or by the time I get out of the grocery store or Walmart or wherever I'm shopping, I'm hanging on the cart to get out of there like it's a walker. Those are obvious times that to consider uh, doing joint replacement surgery. But really, you're the one that has to decide. Your husband or wife can't decide for you. I can't decide for you. That would be the most inappropriate reason to have it done because we're not going through the surgical procedure. You are, and it's a combined team approach. So if you're not all in and ready to attack it post-operatively, you're certainly not going to have a good result.
So if I need a new hip and a new knee, which should I have done first?
Well, the old adage is have the hip done first, because the knee pain may improve. If when you look at how we go through our training, when we do our pediatrics, they always tell you, knee pain in a kid is a hip problem until proven otherwise. And so a lot of times the referred pain that you're having down into the knee area may improve with getting the hip done first. But if the knee is hurting you more than the hip, you may want to do the knee first.
What is PRP?
PRP is platelet-rich plasma. So PRP is your own blood that we draw from your arm, and it's spun down in a centrifuge to get a high concentration of platelets, which is then maintained in sterile concentration and then injected back into whatever area of the body that you're trying to treat. So it's sometimes used in athletes, like treatment of acute medial collateral ligament tears or something of that nature. And we've been using it now in arthritis to treat arthritic knee and hip symptoms. However, you have to remember if you're injecting the hip with it, you can't just do that in the office. That needs to be done in the surgery center under fluoroscopic guidance. And if you're injecting the knee with it, that can be done in the office. And the reason why our practice isn't out there advertising on the radio and telling everybody come and get your PRP injections from us is because from an ethical perspective, it's something once we talked about that's not covered by your insurance. It's cash out of pocket. And so if a patient comes in and inquires about it, we can have that discussion and talk about it. I'm not 100% sure what the cost out of pocket is to patients in the practice right now. There's different iterations of the PRP that we've gone through with different companies. So I don't know where we're at with the pricing on that right now.
What is the sorry?
Go ahead.
What is the recovery time for cartilage repair?
So that's going to be about a 6-month recovery. If you're on crutches in the knee, you're on crutches for 6 weeks, and you're allowed to bear weight on it, but not bend it. And you're allowed to bend it and not bear weight on it, kind of like a meniscal repair. But like we talked about before, there's very few patients who are actually candidates for that. It's really for isolated cartilage defects, usually from a traumatic event, and patients are usually younger, under 30, 35 years old. The one patient that had that scaffolding put in there was a police officer that was involved in a event with another person and injured his knee, shearing off the articular cartilage in there. And he's gone back to full-time police work without any restrictions, and it's done exceptionally well.
What is a multimodal pain management?
So like we talked about, multimodal pain management involves multiple sources of trying to control the pain. So from a non-medication perspective, icing, maybe the icing compression device can help with that. Narcotic pain medications, anti-inflammatory pain medications, neurogenic pain medications. So different things to help maintain a lower pain, but it's painful surgery. No matter how you cut it, no pun intended, it's painful surgery. So we're doing everything we can to help minimize it, but nothing can eliminate it completely. And that's why really, when you make your mind up to do this, you need to be committed to it and want to go ahead and get it taken care of.
How soon can I drive after a total knee replacement surgery?
Well, if we're doing it outpatient, you can't drive yourself home. But I tell patients that the first visit, 2 weeks post-op, that you can drive after that, anytime after that visit, as long as you're not taking narcotic pain medicine while driving, and you can handle the gas and the brake in the car. We joke about it, usually tell them to practice in an empty parking lot because we don't want them playing bumper cars. But if they can control the vehicle and be able to start and stop effectively in the parking lot after 2 weeks post-op, then it would be okay for them to drive.
Does taking glucosamine and chondroitin or omega fatty acid supplements actually help with arthritis?
Well, like I said, there's nothing that I've seen with a good double-blinded study that proves that it does, but there's enough patients taking it that say that they get relief with it, that it's something to consider. I usually tell patients take it for 3 months. If you notice a difference, continue taking it. If you don't notice a difference, then certainly stop. It's also people that are taking turmeric as a natural anti-inflammatory and things like that.
If I'm missing most of my meniscus, is that considered a local defect or a global defect?
Well, the meniscus is like the shock absorber that protects the knee. So if you're missing most of your meniscus, it's going to lead to a more global defect in the joint.
In my experience, doing PT makes my knee hurt more, not less. I have been doing the exercises for about 7 weeks now.
Well, that may be a sign that like I said, the horse is out of the barn and running, and it may be that you need more done than just physical therapy. Our goal is to keep you active because motion is life, motion is lotion, they say, and motion is life. And when you stop moving and you stop being active, it's the beginning of the end, so to speak. And so if being active and doing things in physical therapy makes you a lot worse, as opposed to sitting around and doing nothing, we obviously want you to be active as opposed to doing nothing. So, but the more sedentary you become with arthritis in general, the more symptomatic that you'll become. So maybe the physical therapy you're doing maybe should be converted to a water-based program, and that may help a little bit more. Maybe try that. I know our Westerville office offers a swimming pool. If you're doing it with us, you may want to see if they can incorporate that into it.
What is the cause of fluid on the knee?
So fluid on the knee, the definite or the term for that medically is called an effusion, EFFUSION. And it's so there's a normal amount of joint fluid that's made by your synovial lining of the joint. So that lining, when it gets irritated, will make more joint fluid. Also, there's been some research that shows that it can be neurogenically mediated. So like, for example, some patients that have had a tourniquet put on their leg will have chronic swelling in the joint, and going on like a nerve pill like Neurontin sometimes helps with that if it was traumatically caused by the tourniquet or something of that nature. However, from just an arthritic perspective, what happens is you break off little pieces of articular cartilage that starts to float around in the joint. It irritates the synovium. And it's kind of like at that point, then a dog chasing its tail. and it just keeps causing more and more inflammation in the joint, and that inflammation causes more joint fluid to be made and more swelling in the joint.
Does waiting too long for knee or hip replacement cause long-term issues to other areas of the body?
It can. I mean, if you have a gait that is so off that it's affecting your lower back or other joints in your body, it can be a problem. And waiting so long that you have so much erosion of bone can be a problem also in trying to get the knee, if it's a knee replacement, balanced correctly, and or the components of a hip to fit in there properly.
Can you describe how PT helps with arthritis?
So PT allows for working on things like range of motion and strengthening of the muscles of the affected joints so that the knee and hip function more ergonomically the way that they were designed to function as best as possible. But regaining as much flexibility as you can without hurting the patient in physical therapy would be the first goal. The second goal is strengthening the muscles around there, and in doing that, it allows the joint to function as normal as possible, and limit the amount of pain. So, some stress on an arthritic joint is good, and will minimize symptomatic pain. But excessive stress, overdoing it, then will get the opposite effect.
And the last question that we have so far, if you have any additional questions, please put them in the Q&A box. When using a cane, what side should the cane be on? The side with the surgery or the opposite?
The opposite side. So if you had a right hip replacement, you should use the cane in the left hand. And the same thing with the knee. If it's a right knee replacement, use it in the left hand.
Thank you, Dr. Cannone. Any additional questions?
There's got to be one more. So nobody asked what the components are made of, and will I set a metal detector off after joint replacement? The hip components, for the most part, are titanium in the stem and the cup, a plastic liner that goes into the cup, and then a ceramic head that goes on the end of the stem. None of that will set a metal detector off. And the good news is those are bioingrowth components, so the bone wants to grow into titanium. The knee components, in general, the tibia is more of a titanium component, and the femur is more of a mixed metal alloy, a cobalt chrome alloy, and that will set a metal detector off. There's a plastic spacer that goes in between the components and the iris surface, the kneecap, so there's a plastic spacer that goes on that. And the other thing that you need to think about before having joint replacement in the hip, it's not a problem because it's titanium that we're dealing with, but in the knees, you need to know whether or not you have any metal allergy, whether you have some type of allergy to nickel. It can be an issue with knee replacement and cause excessive swelling, pain, and stiffness. And so if we can know that ahead of time, it will hopefully put off some prolonged recovery and prolonged disability after that procedure. The problem is it's just too expensive to metal test everybody out of pocket. You're looking at a $600 to $1,000 expense. And to have every patient tested before surgery, it's cost prohibitive in most instances.
We got a couple more questions. How big of a concern is infection after a total knee replacement?
And so, I mean, obviously infection is a concern after any surgery that we do. We do everything we can to minimize the chance of infection. So it's a multi-faceted approach to that, by using a special soap to clean with before surgery, and then get a chlorhexidine wipe the day of surgery. We don't shave the skin any longer. We clip it. It's called clipping it with an electric clipper, as opposed to putting a razor on there and shaving it. That helps diminish the risk. We do decolonization the day of surgery for MRSA with nasal swabs. And if you have a history of MRSA, we want to know that because there's different antibiotics that we want to use. If it's a cemented knee replacement, we put vancomycin in the cement to leach out over time to hopefully prevent any type of infection in there. And in a hip or a bioingrowth knee, we'll sprinkle the joint with vancomycin when we're done. We also use special irrigation to help prevent infection. And in revision procedures, we use a special dressing, and sometimes even in primary procedures, it's a suction type dressing, and it's been shown to diminish the risk of infection and help with wound healing. The downside of that dressing is you really need to use staples in the skin to get the best result. And we usually close our primary joints with glue. So you wouldn't be doing that. The other thing that we've seen in recently, a lot of patients having reactions to either the soap or the glue or the dressings that are put on that we hadn't seen. But in the last couple of years, a lot of red wounds that initially we thought maybe we're dealing with infection, and it's not. We're dealing with allergic reactions. So those are treated with topical steroid ointment or cream. And sometimes we even do some oral steroids to help calm that down.
Why do you have pain in your knees if they touch during sleep?
So I don't know. I can't give you a templated answer for that. I mean, it could be because of the arthritis that you have in the joint, and those arthritic areas are touching and causing discomfort. It could be part of this whole process that we're finding out is that there is a significant neurogenic component to arthritis. And the reason why I say that is because we've had a handful of patients that have had these NALU stimulators, nerve stimulators put on before surgery. And the handful of patients have said that, I'm getting, close to 85% of relief of my pain before we even replace the joint. So there is some type of neurogenic component to that. And part of that with the knees touching may be neurogenically or nerve related also.
Okay, that was our final question. Thank you for participating in tonight's webinar. Our next webinar will be held on May 13th. Dr. Rod Komisar will speak on common knee injuries in sports and how to tell when your knee injury is serious. Enjoy the rest of your evening. Good night.
Thank you all.